or longer?
I will prefer if you take it for 3 hours.
3 hours.
I mean, just finish the andrology as much you can, IO, please.
Okay. Well, if we've gone too long, just let us know, and I'll try and get through as many scenarios as possible. Okay.
Nothing is too long in andrology. In andrology, everything is long.
Very true.
I hope I'll be alive after 1 or 2 hours.
Okay, we'll see how he gets on, and
sure.
We'll see how the trainee gets on as well. I guess an hour is probably what I was aiming for. Otherwise, it might get a bit tiring, but we'll see.
Yeah. Normally we do 1 hour videos, but it can go here. Yeah, that's fine. Yeah.
Okay, I've got lots of scenarios.
Yeah, sure. And one thing that we have another 75 days. So I worked a bit hard. Let's see how far I go. Yeah.
Okay. Should I start?
Yeah, we can.
Okay. Good afternoon. This is a YouTube recording of andrology scenarios for the FRCS Urology Viva course. We've got a trainee with us today. We're going to work through as many scenarios as possible. Could the trainee introduce himself?
Yeah, I'm a senior CS doctor. I'm sitting for my Viva in May 2021. So we are in February, end of February now. I'm very happy to record the sessions for the use of future trainees and to be aired in YouTube.
Okay, brilliant. Thank you very much for that. The first scenario, we've got a 65-year-old gentleman who attends your clinic complaining of poor erections. How are you going to assess this gentleman?
I would like to see him in the dedicated andrology clinic, preferably with a partner. I would take a focus history and examine and arrange necessary investigation. In the history, I would like to know whether this erectile dysfunction is a sudden onset or gradual onset, and what is what is his concerns and what is the trouble he has. I want to make sure that it is a pure erectile dysfunction rather than other associated abnormalities in the erection, such as Peyronie's disease or retrograde ejaculation at the outset. And moving on, I would like to know whether he had any past history of the similar problem, and whether he tried any medications over the counter or the GP has prescribed any treatment in the past. And also I would like to know about his partner, the support in making arousal before the sexual intercourse starts. And also I would like to know about his medical history, whether he has diabetes, hyperlipidemia and hypertension or any other medical illnesses, whether he's taking any regular drugs such as antidepressants, antipsychotics, or any hormonal treatment, if he's taking treatment for his prostate cancer, if he has, or any anti-androgens and so on.
Okay, what are the major, I'm going to interrupt, what are the major risk factors for poor erections?
It could be arteriogenic. So diabetes is one of the common causes that we see in the clinical practice, and also erectile dysfunction can be a marker of future cardiac health. So in my evaluation, I also, at the back of my mind, I would think that the patient has a cardiovascular evaluation from the GP, or if not, I would alert the GP to do that, or I would order the basic investigation. So the cardiovascular health it could be a marker of cardiovascular health, an onset of erectile dysfunction.
So what sort of risk factors would you be looking for in the history?
Yeah, diabetes, hyperlipidemia, and drugs. And previous trauma, anything neurological disorders, hormone dysfunction such as hypogonadism.
What about iatrogenic risk factors?
Iatrogenic, it could be, because commonly, like when the men get older, we don't find any cause sometimes. Yeah, that falls into iatrogenic risk factors as well.
No, iatrogenic are things that we've caused as surgeons.
Yeah, I'm sorry, I got confused with idiopathic. Sorry about that. Yeah.
That's okay.
Yeah. Hydrogenic risk factors, yes, any surgeries, whether pelvic surgeries, prostatectomy, any pelvic surgeries can cause erectile dysfunction, yes.
Also radiotherapy.
Radiotherapy,
Well.
yeah.
So this gentleman tells you he's had gradual onset erectile dysfunction. Really, it started slowly after he had some radiotherapy for his prostate cancer. His prostate cancer is now under control. His PSA is unrecordable. He's not really getting early morning erections, and he's not able to get any erections with his partner or when he masturbates. He's tried sildenafil with no real help. He's also diabetic, and he's on metformin, glycoside, bisoprolol, and that's it. Is there anything else that you'd want to know from that?
Yeah, there are a couple of things I want to make sure at the start. One thing is how much support he gets from the partner, because we know sildenafil is a drug that it needs a good foreplay for the drug to act. So I would ensure that he gets adequate sexual stimulation before he starts a sexual act. One thing. The second thing is I want to know how he takes the drug. For example, like it has to be taken at least within 1 hour of the proposed intercourse, and also he should take it on the empty stomach. So these things I would like to know before we move on to the next step. And also I would like to know what patient wants from us as well.
Okay, so he wasn't really given any information about sildenafil. He just took it expecting it to work. He can't remember what dosage he took either. He said he got it from his mate down the pub. What investigations are you going to arrange for this gentleman?
I would like to know his diabetic control, fasting blood sugar, and HbA1c would be helpful in this patient. If previously he was not investigated for cardiac risk factors, a fasting lipid profile would be useful, and also those are the investigations. Since he is on, may I know that whether he is on any hormonal treatment for his post-radiotherapy cancer?
No, he's not on any hormone therapy anymore. Anything else? So you've talked about his cardiovascular blood tests. Anything else you want to do? Any other blood tests?
Lipid profile, and that's what I can think of now.
Any hormones?
Yeah, testosterone would be helpful. Yeah, I'm coming to that. Yeah. Testosterone
when do you want him to do the testosterone?
We advise fasting testosterone between 9 o'clock and 11 o'clock. So in my practice, I usually book for a 9:30 sample. I ask them to come fasting and then come at 9:30 to the lab and to get the blood test. Because of the diurnal variation, we ask them to come in the morning. And also it has been found that fasting of testosterone is better.
Okay. Any other ways of assessing his ED? Anything else?
Yeah, we have a validated questionnaire, IIEF 5 questionnaire, which is a validated short form of IIEF, International Index for Erectile Function questionnaire. It tells us about its erectile function, which can be used in follow-up as well. It has 5 domains, which talks about they are confident about the erectile function one, and about the penetration, and whether they can maintain a penetration until ejaculation, and then we can maintain penetration throughout the sexual intercourse. And finally, it tells us about the overall satisfaction of the sexual function. We can grade this from 1 to 25. So 1 to 7, we call it severe erectile dysfunction, and 8 to 11 it's moderate, and 12 to 16 is mild to moderate, and 7 to 21 is mild, and 22 to 25 is normal erectile function. So this will give us an idea in the initial assessment and the follow-up.
Okay, so this gentleman's got normal testosterone. His IIEF score is 10. All his other, he's a moderately well-controlled diabetic, and he's an ex-smoker. He's on bisoprolol, and his blood pressure is well controlled. How are you going to manage him?
So he has, as I told earlier, I would make sure that he is taking sildenafil correctly. If not, I would give him a chance to take the optimal dose of 100 milligram or maximum dose of 100 milligram as needed basis. On top of that, I would advise him about lifestyle changes. For example, optimal control of his diabetes, and also if he's overweight, I would advise him to do some exercise and reduce weight. That would help. If that is not working,
I'm gonna interrupt you there. Is there any evidence that lifestyle changes actually improve erectile function?
I have read in books, but unfortunately, I'm sorry, I can't quote any paper. Sorry about that.
Okay, so there are two good randomized controlled trials. They're quite a bit old now, and they both show that there is an improvement in erectile function if patients stop smoking and lose weight if they're overweight. So you've given him advice about lifestyle changes. You're going to start him on. Is there a PDE5 inhibitor you're going to start him on?
He was already on sildenafil. According to the NICE guidelines, we have an option to change it to a different medicine. So a trial of tadalafil would be tried. So we can start with 10 milligram dose, and he can go up to 20 milligram dose. The benefit of this is the benefit is like its spontaneity of the erectile function can be expected. So sometimes you might feel better. So that option is there, but I will discuss with the patient about the options. Like if he wants to consider other methods of treatment for erectile dysfunction, I would offer that. Or if he's happy to try another tablet, I would go for tadalafil at this point.
Okay, so he's happy to try tadalafil. How do PDE5 inhibitors work?
The basic action is it prevents the conversion of cyclic GMP to GMP. So how it works is the erectile function from the nitrous oxide, so it changes GTP, guanylate triphosphate, to cyclic GMP via the action of guanylate cyclase. So this cyclic GMP is the one which causes erection through the protein kinase G. It causes intracytosol reduction in calcium, by which it causes smooth muscle relaxation in the cavernous vessels. So by that, it causes erection. So later, this cyclic GMP is converted to GMP. So this is the place where the PDE5 inhibitors help. It will prevent of this transform. So the more cyclic GMP will be available for the action which I described earlier. So the erection will be maintained.
Okay. Are there any contraindications or drug interactions that you need to be aware of when you're prescribing PDE5 inhibitors?
Yes, absolutely. The contraindication wise, if the patient is on regular nitrates, it's contraindicated. And if the patient is on any antihypertensive, it's relative contraindication, or we have to be very cautious in that. And if the patient is known to have hypotension, you shouldn't give. And other contraindications include recent history of cerebrovascular accident, recent history of myocardial infarction, and if they get angina while having sexual intercourse, that is again a contraindication. As far as the drug interaction is concerned, it depends on the type of medicine that we use. For example, if you use tamsulosin, we should advise them, if they take alpha blockers, we should take at least, they should give 4 hours interval. So if the patient is taking alpha blockers for a long time, my usual advice is to take it in the morning and then take the PDE5 inhibitors at night. And also if they take off and on as needed nitrites, I would advise him, if they take the nitrites should not be taken within 24 hours after a tamsulosin or 48 hours after tadalafil. And the other advice, important advice, the reaction with the food intake. So if it is tamsulosin, you tell them that not to take it in an empty stomach. But tadalafil, you don't have this problem.
And what are the side effects that you need to warn him about?
Yeah, one thing is they can have, the mainly side effects are due to the vasodilatory effect. So they can have headache, facial flushing and puffiness in the nose, dyspepsia. And there are certain side effects peculiar to certain drugs. For example, tamsulosin can have blurred vision, and very rarely it can cause. And also tadalafil can cause back pain and myalgia through PD11 inhibitors.
So he comes back to see you about 6 weeks later, and he actually got some more sildenafil from his GP. Tried 100 milligrams, didn't work, and he's tried tadalafil at 20 milligrams, and that didn't work either. He wants to know what other treatment options are available.
Yeah, the treatment options at this point would be using a vacuum pump device, or we can move on to alprostadil, either intracavernosal injections or intraurethral preparations, or at the last resort, he can have a penile implant, which should be a last option because it's irreversible. So if I want to explain him one by one, the vacuum pump device, it's a good method. You don't have any medicine. It works on the principle of creating a negative pressure, which increase the blood flow to the penis. They can have a erectile function. They should have a good hand dexterity for these methods to be used. Otherwise, the partner could help. That is one option. The other option is using prostaglandin 1 inhibitors like alprostadil. This could be a form of intracavernosal injection. Usually we give the dose starting from 10 micrograms, 20, or I have seen in some patients they take even 40. Otherwise, we have other preparations which is called Muse, that is the urethral system for erection. So that is a pellet sort of thing. It's inserted into the urethra, or else recently we have Vita, the intraurethral cream as well, which is used at a dose of 200 or 300 microgram with 1 gram cream formation, so which can be used.
Okay, so he's quite interested in Coverject. He wants to know what the pros and cons are between Muse and Coverject.
Well, first of all, I would tell him that Coverject is an injection, so he has to inject, so a pain can be associated with that. But the benefit of Coverject over Muse is it has a better response. Around 70 to 80% patients can have good response of that. The cons of this is, as I told, it's pain and it can cause fibrosis, and if the patient is taking anticoagulants or bleeding disorders, they won't be able to have this, and also a risk of priapism is also there. On the other hand, Muse is easy and simple to use, and the other thing is for intracavernosal injection, somebody has to inject, or he should have a good manual dexterity. On the other hand, Muse, it's easy to use, but they can have hematuria or the pain in the urethra or irritation. This can happen, and the effect also is not good as Coverject injections.
Okay, so he's really keen to try Coverject. So he's gone home. You started him on 10 micrograms. Is that right?
Yeah.
Okay, so about 2 weeks later, you get called. You're on call. You get called to the emergency department because he's presented with a prolonged painful erection. What's going on?
I would suspect he's developed priapism in this case, since he's on Coverject injection. So I would see him and take a focus history again.
I'm just going to interrupt. What's priapism?
Priapism is a prolonged erection lasting more than 4 hours, which is not related to the sexual act after 4 hours. So it's a prolonged erection more than 4 hours.
Mm-hmm. And are there different types of priapism?
It could be a ischemic priapism, or high flow priapism, or a stuttering priapism. These are the different types.
Okay, what's he most likely to have?
Sorry, I couldn't hear.
What's he most likely to have?
It most likely to be ischemic priapism because of a prolonged erection.
Okay.
What
are some of the other causes of ischemic priapism?
It could be due to sickle cell disease, one of the common causes we see in clinical practice, or it could be due to any hematological malignancies and recreational drugs, antipsychotic medications. All these can cause ischemic priapism. Mm-hmm. And the treatment for erectile dysfunction, such as intracavernosal injections.
Okay, how would you manage this gentleman? What do you want to know in the history which will help you?
Yeah, first I would like to know about the mode or possible cause. Even though he has taken he's taken Coverject, I would ensure that this is due to Coverject injection, and I would like to know the duration, if it is more than 4 hours, confirm, and then I would examine to make sure that he still have rigid erection, which is going more than 4 hours. And then I would start my management. I would send a blood for assessment to see the pH and
How are you
pressure.
going to how do you do that? How do you take a blood gas?
Yeah, well, I would explain him about the procedure. I would take consent, at least a verbal consent, and I would clean. And usually in my practice, I give a local anesthetic. Usually, I give 10 milliliter of levobupropion 0.5% and 1% of lidocaine 10 milliliter without adrenaline. After the local anesthetic, the penile block is given, I will take a small needle, the BBG needle, and then I take sample, the blood sample from the side of the corpus cavernosum and send it for assessment. And this will be so I'll ensure that it's a low flow priapism, and then if it is confirmed, I will start the aspiration.
How do you confirm it's a low flow?
The pH will be less than 7.2. There'll be acidosis, so less than 7.34, and also partial pressure of oxygen will be less than 60 kilopascal. And then I'll move on to aspirate. That would be my first option of management for priapism. So with a large bow needle at the side of the corpus cavernosum, I will aspirate the blood until the erection is gone, or I see bright red blood. So I would aspirate approximately 200 milliliters. And then I have an option to give a flushing as well. I know some people do that, but which I don't do in my practice. And I would see the response, and if it is responding, well and fine. Otherwise, I would go for the second option that I can give.
I'm gonna, before you get to the second option, you said you're gonna aspirate on 200 mils from the penis. How much blood do you think the penis normally holds?
Sorry, I don't have a figure. Sorry about that.
Okay. Much less than 500 mils. When the blood comes out, what are you expecting it to look like? Is it going to be easy to come out or difficult?
No, it's easy to come out. Usually the blood in the priapism, they don't clot, so it's easy to come out. If you really hit a place where you can drain, it's easy to come out.
No, that's not true. It's very difficult to come out, and it is clotted blood. So it's dark congealed clotted blood. Very difficult to come out. That's why you put a large bore cannula. And that's also why you often have to flush it as well. Okay. But your management was correct so far. So you've tried to aspirate it with your large bore needle. You got a little bit out, nothing. It hasn't gone down. So what are you going to do next? You've also flushed it. What are you going to do next?
Yeah, I will go for injection of phenylephrine. That is the second option, which is alpha agonist, which helps to achieve the tumescence. So this one, the patient should be under strict cardiac monitoring because it can cause hypertension. Usually what I do is I'll follow the advice given by the Bowes consensus for priapism management. So I take one vial, which is 10 microgram, and then that is 1 ml, 10 milligram in 1 ml, and then I dilute with 19 milliliters of saline, make it 20 milliliters. And I'll give 200 microgram alicate at once with 0.5 ml, and then I can repeat this every 10 minutes, maximum of 1 milligram within 1 hour. So if it is needed, so if it comes down within 1 or 2 injections, I won't continue, but the maximum I can go up to 1 milligram within 1 hour.
Okay, you should really give about 200 to 300 micrograms every 3 to 5 minutes. Otherwise, you'll be there a very long time. Okay, so you've done that. That still doesn't work. What are your options now?
The next option is for shunting procedure. So I know of it could be proximal and distal shunt. Usually, the first option is distal shunt. So
is there anything that would make you not want to do do a shunt? How do you decide whether you do a shunt or not at this stage?
The response, like if it responds, you don't need to, but if it is not responding,
No, it hasn't
then
responded. Hasn't responded. Would you always move on to a shunt?
we can wait and see if it responds,
No,
because
it hasn't responded. It's an emergency. So if he told you in the history that this had been going on for three days or more, would you do a shunt?
no, it depends on the time period. According to the guidelines, it's Bow's consensus of privacy management. If the patient presents within 48 hours, yeah, you can go for shunt procedure, or if it is more than 48 hours, you have to straight away you should go for a penile implant, because the response is less. There is a paper which I read, but I forgot to quote that. Yeah, there's a paper on that. We have evidence for that. So if it is more than 48 hours, you have to go for penile implant.
Okay, so let's say it's less than 48 hours, and you're going to take him to theatre to do a shunt. How do you consent him for that?
I would tell him that this will be done under anesthesia, and I would explain him why we do that, because it has not responded. The privatism has not responded to the management. So I would tell him that we have to take the blood out by creating a passage through his the glans penis, and then drain the blood, so that will help him. The risk-wise, I would explain him after the procedure, it might cause infection, bleeding later on, and there's a small chance of erectile dysfunction because of his prolonged priapism and the procedure itself. So after explaining and then consented the patient, properly draped and prepared patient, the shunt procedures we know is winter shunt or Ebhoj or T shunt. These are the first shunts that we can do, and then we can move on.
Okay, so he comes back to clinic. The shunt works, by the way. He comes back to see you in clinic. He's missed a few appointments, and he turns up in your clinic 6 months later, and he has had no erection since the episode of priapism. He's very distraught. He's got a new partner who's 20 years younger than him, and she's very sexually driven. He wants to know what the next step is.
Okay, so in this case, it's most likely he has a permanent damage due to his previous priapism episode, a prolonged one. I would counsel him for a penile implant at this point, and I would refer him to the tertiary center where it is done.
Okay, what do you think? He wants to know before he goes. What can you tell him about penile implants?
First thing, I would tell him that it is a surgical procedure. With the risks of the surgery, I will come to that. And the one thing he should understand, it's an irreversible procedure. Like if once we've done that, he won't be able to have, if done that and then if it fails, he won't be able to have any other forms of medical or conservative management in future. And I would tell him about I would discuss him about the procedure. I would give him a Bow's information leaflet on this. I would show him the picture of the penile implant. I will tell him that we have different types of penile implant, that it's malleable 1 or 2 piece or 3 piece penile implants. And the risk I would warn him about is that it can, in the short term, he can have infection and rejection and erosion and need for removal of the implant if it's not working for him, and the possibility of mechanical failure later on. But I would ensure him that in around 80 to 90% of the patients, they have erectile function restored with this method. But I would warn him that it is not the normal erection that he has. For example, like normally he has warm and rigid erection, but this will be cold and rigid erection. And also I would warn him that he'll have drooping of the glans penis even after the penile implant insertion. So these things I would counsel.
Okay, you've sold a very negative picture to him. He's quite worried about this. What are his options if he doesn't have an implant?
He can
tried everything. Nothing's worked. Okay, so the penile prosthesis is actually probably has one of the best efficacy outcomes of any surgery we do. You have to be very careful when you're counselling somebody that you're not unduly negative. It works better than a TURP. I mean, a TURP has an efficacy of 66 to 70%. An implant has an efficacy of patient satisfaction consistently of 80 to 90%, over 90% in some series. So although, you know, it's irreversible, most patients are happy. There is no alternative when they get to this point, when they've tried everything else, unless they just don't want to have sex the rest of their life. Infection rate is in a diabetic, in the high volume centers, probably about 5 to 10%, probably 10%. In the non-diabetic population, it's about 3%. Erosion tends to go with infections, and again, that's very low. And complication rate is also very low. So, you know, it's a good operation, it's a good option. So you have to give a more balanced discussion with the patient. Okay. So we're gonna move on now. He's gone off to see me actually. I've put in an implant, and he comes back to see you. He's very happy that you referred him, and his wife's marrying him. So his son, because you did such a good job, his son's come to see you. His son's 30, and he's been referred to you from his GP with infertility. He and his partner have been trying for a baby for 3 years. What are the key features that you want to elicit in the history?
First of all, I would like, preferably, I would like to see him with a partner. So I hope he's with a partner.
Yeah, his partner's arrived too.
First thing, I want to make sure that whether they are trying for more than 1 year unprotected regular sexual intercourse before I label him as infertility. So that's the first thing I would do. And then I would like to know about the history. I would like to take a history from him, whether it's a purely erectile dysfunction or let me rephrase it. Yeah. So I would like to know whether he has any erectile dysfunctions, premature ejaculation, and so on. And I want to know whether he had any past history of undescended testes or testicular surgery or chiropexy or hernial surgeries or any surgery involved the scrotum. And also I want to know whether he has any medical history such as diabetes, hormonal dysfunctions, hormonal disorders and all. And I also want to know about his general lifestyle, whether he use any excessive steroids or any hormonal treatment, or whether he goes for regular sauna or hot bath, or whether he use laptop on the lap for a long time and so on, just to make sure. And any recent history of febrile illnesses, any other medical history like HIV, hepatitis. On top of that, I want to know about the partner, her age, her menstrual history, whether she was investigated for subfertility, whether she has, whether either of the partners, whether they have children from other marriages or other relationships. Yeah, these things I would consider in my history. And then I move on to examination in this gentleman. I would look for general examination, his build, whether he's obese, and his waist circumference, and also the development of secondary sexual characteristics and virilization. And moving on to the penis, any obvious penile deformities, meatal status and foreskin status. And in the scrotal examination, I would examine the testis for its size, consistency, any other abnormal lesions or palpable mass. In the standing position for varicocele examination, I also would like to know about the epididymis, whether I can feel the epididymis, head, tail, and body, and any swelling in the epididymis or enlarged epididymis, presence of vas bilaterally. These things I would do. And he has a family history of prostate cancer. Even though he's young, I would complete my examination with a DRA in this gentleman.
Okay, so his partner's 39. They're both normally fit and well, no significant comorbidities, and this is primary infertility. On examination, He doesn't have any obvious congenital abnormalities. He's got both his testes. They're a little bit small and soft, actually, on both sides. What tests are you going to do next?
I would like to do a semen analysis and a hormone profile, including FSH, LH, testosterone, and if indicated, I might consider prolactin as well, depending on my examination finding. And also, I would add hepatitis B and C and HIV level as well.
Why are you checking those?
Because if we want to go for assisted techniques, it has to be done in a specialized place if it is positive. So to plan that, because the partner is 39, if problem is identified, there's a high chance that they might go for that.
Okay, so you want him to have how would you explain to the patient how to produce a semen sample?
Following advice I would give, I would give him a bowels information leaflet. We have a nice information leaflet. So I'd give him, on top of that, I would explain him that it should be a sample which is taken with abstinence of sex or masturbation 3 to 7 days, at least 3 days. And I would tell him the best method is to collect is masturbation and collect rather than using a condom or any latex. And also, I would tell him that he should transport this immediately, preferably within 30 minutes to the lab, because it has to be evaluated within 1 to 2 hours. So these things I would tell him, yeah.
Okay, so his semen analysis comes back. Have you got a pen?
Yeah, I'm writing all this, yeah.
So the volume is 4 mils. There's no sperm identified. There's a pH of 7.3. Fructose of 13, his hormone profile, his FSH is 15, his LH is 7, and his testosterone is 12. Did you get all that?
Yeah.
Okay, so how would you interpret those results?
So he has normal volume with azoospermia with normal pH and fructose, and his hormones are normal. Testosterone, yeah, I would say it's low level of normal, but still it's normal. 12 is normal, yeah. So his semen analysis and the hormone profile suggestive of normovolemic normovolemic obstructive azoospermia picture.
Okay, are you sure that's obstructive? What makes you think it's obstructive?
Because he has an I'm sorry, I made a mistake. His FSH is high, 15 is high, so it's a non-obstructive azoospermia because of high FSH level. Sorry about that.
Yeah,
non-obstructive
that's good. You were right the first time. So how are you going to manage this gentleman who wants to have a baby, he and his partner?
Okay, we need a good conversation with the patient and the partner, especially the partner is 39 years. So the important point to know here is what is their expectation, how many children they are planning to have. Since the partner is 39, and if they are looking for one child, the best option of management would be to go for assisted surgical sperm retrieval and then assisted technique. But before that, I would like to do some more investigation for him, such as karyotype, because of azoospermia, and also microdeletion, to look for by microdeletion.
Why is that important, microdeletion?
Because if it is present, it can, two reasons. One is if it is present, it can go on to his male offspring, that is one. The second reason is if it is type A or B, we don't, there's no indication to go for a surgical sperm retrieval, the chances are 0.
Okay. Okay. So you do that. He doesn't have any microdeletions and his karyotyping is normal. So what are you going to do next? So you said you're going to refer him for
surgical sperm retrieval and ICSI.
Which surgical sperm retrieval option is the best chance for him?
My first choice would be micro TC, because we have 50% of chance that we take a good sperm, and considering the partner's age, I think that would be the best option for him at this time.
Okay. So he wants to know how this procedure is done and what are the risks.
Okay. It's done under anesthesia, so the scrotal incision is made. Before that, we will explain the patient why we are doing this and take consent, and we'll tell him about the need for this. Our aim is to retrieve the sperm later to go for a ICSI procedure, which is a assisted fertility technique, and the risks of this is infection, bleeding, hematoma formation, and loss of testicular volume, even though micro-TC is very less. And the chance of non-retrieving a sperm, that is also there, so he should be able to understand all these. And then the procedure-wise, it's under general anesthesia, properly prepared patient, draped and clean patient. We do a scrotal incision, deliver the testes, bivalve the testes, look under the microscope for active sperm, and then these are retrieved for ICSI, and some of the sperms also will be stored for later use if this is failed.
Okay, so if his genetics had shown a karyotype of 47XXY, what would that mean?
I would say that means this patient is having Klinefelter syndrome.
Mm-hmm. And what's the significance of that in this couple?
Usually they are subfertile.
Mm-hmm.
The significant wise. So, we have to go for a surgical sperm retrieval at early stage rather than trying other treatment options.
You still need to go for surgical sperm retrieval. Their success rate is lower, and they often over time they'll start off with a testosterone that's probably low normal, and it might then become subnormal, so low. So they need to be managed by an endocrinologist long term. They also need to see a genetic counselor as well. Okay. You've got another clinic, so he's gone off to have some micro-TZ. Got another chap who's next after him. He comes to see you, and he reports that he's had a curvature in his penis for about 6 months now. He wants to know what's wrong with his penis.
How old is he?
He's 55.
55 years, okay. So a curvature in the penis give a suspicion that this patient is suffering from Peyronie's disease. So I would see him in the clinic and then do the needful for him depending on what he wants. Do you want me to tell how I will?
He wants to know what Peyronies is.
Okay, so first thing I would tell him that the exact mechanism is not known, but there are certain hypotheses. That is the repeated injury to the microtubules, which cause the inflammatory response, and deposition of collagen, which forms a plaque, and finally it causes a penile curvature. So that is the understood basis or cause behind Peyronie's disease, as far as I know. So that's what I would tell him.
Okay, so
yeah. Sorry.
No, go on.
And I would tell him about the disease, a little bit more about the disease, the nature of the disease. Particularly, I would tell him that it is a progressive disease which has different phases. One is acute phase, where they have pain and progressing curvature, this will turn into a chronic or stable phase where the pain settles and the curvature will be stabilized. This is the point where we aim for our definitive treatment. And also the natural history of the disease, like in around 2/3 of the patients it will be stable, and around 20% it will get worse, and in around 10% it might improve as well. And I also would tell him that it might be associated with some other conditions such as Dupuytren's contractures and Ledderhose disease. Okay. And also it can cause the Peyronie's itself can cause erectile dysfunction, the vice versa as well, and diabetes is also a known cause for this. So these things I would give him a brief idea about the disease.
Okay, so diabetes isn't a cause; it's a risk factor for it.
Yeah.
Okay. So what questions are you going to ask him to assess him in the history? Just
okay, so
questions.
So you told me that it is 6 months or 6 weeks? Sorry, I missed it.
6 months. So he's had
6
it for
months.
6
Yeah.
months. Yeah.
So that is the borderline for a transition of from the acute to chronic phase. I would ensure that whether he still have pain or he the angulation is progress or stable by now, and I would like to know about his erectile function, whether he has good erection, and if he had erectile dysfunction, whether he is using any forms of treatment, PD5 inhibitors, whether it's responding to that, and also his degree of bother, whether he can have a sexual intercourse, or he or his partner has pain or discomfort while he's having sexual intercourse, and also his other medical history like diabetes and other medication he's taking, if I plan for surgery, and if there is any past surgical history, and his concern and expectations, what he wants from us. I would ask that at the initial.
When you examine his penis, what are you looking for specifically?
One thing is, if it is a flaccid state, I would look for stretched penile length. I would examine, and also any obvious abnormalities or curvature seen in the penis, and I would palpate for the plaque, where is the plaque, and the size of the plaque, and also the foreskin, whether it's circumcised or not. These are the things I would look for in examination.
Okay, you can't see a curvature in his flaccid penis. So what are the options so that you can assess the curvature?
I would be very happy if he had brought any pictures on the erectile phase, ideally in the different angles that will give me an idea. If not, the option is to induce an artificial erection, which with alprostadil injection in the clinic, and to have to inspect by myself before we plan on the next medicine.
He really isn't keen on having injections in his penis. He said he'll send you a picture, but he wants you to give him information about how he should take it.
Yeah, I would tell him at the maximum erection he has to take one from the top angle and one from the side angle, so that we can see the angulation, degree of angulation, and also the direction. We can get an idea from these two views.
Okay, so you need 4 views. So one from above, one from both sides, and one from in front of the penis will give you the best way to assess it. So he wants to know what the treatment options are.
The first thing I would tell him, it depends on his bother and his expectations. Generally,
he tells you that he can't have sex, he can't penetrate, he's very bothered. The curvature's been stable for 6 months, and he doesn't have any pain anymore.
Okay. So one thing I would tell him, medications have been tried in the past in the chronic phase, but it has not helped much. We don't have much evidence. Basically, latest EA guideline is clear about that. These medications, the oral medications like Potaba, vitamin E and all, is not helping in the chronic phase. And the other option is to use the conservative measures, non-surgical measures, I should say. The use of vacuum pump device like SomaCorrect is helpful in around 70% of the patients. And also we have evidence for use of injections, the Ziapex injections, which we have evidence that it can improve the curvature by 18%. But I know that nowadays in Europe it's not available, so that is a non-surgical option. The ideal option for him is a surgical option of correction of the curvature. If we want to talk about the surgical option, it depends on the amount of curvature, and whether it's less than 60 degrees or more than 60 degrees, and any associated deformity such as hourglass deformity and the patient's erectile dysfunction. So the surgical management would be either a plication technique if it is less than 60 degree. If it is more than 60 degree or associated with hourglass deformity, a plaque incision and grafting is a best choice. And if the patient is not having a good erectile function with or without supportive medicine like PD5 inhibitors, the best option for him is to go for penile implant with or without molding, depending on associated deformity.
Okay, so how would you counsel him if he's going for a Nesbitt procedure?
First of all, I would tell him about the procedure. Why we are doing that is to correct the the penile curvature. Again, here I would use the help of a Bow's information leaflet given beforehand to go through that. So certain important things I would tell him that if you go for Nesbitt procedure, the mode of treatment that we put some stitches to correct the angle. So at the end of the surgery, he might feel the stitches, number one. Number two, the risk of this particular procedure is penile shortening, that I would warn about that to him, and around less than 10% of chance of erectile dysfunction in plication technique. And I would also warn him sometimes we might need to do a circumcision depending on the situation. So I would consent him beforehand if it is inevitable we do a circumcision. And I would tell him 100% correction is not always possible, but most of the time that he will have a satisfactory straight penis to have a satisfactory sexual intercourse.
Okay,
And also I can tell him about the side effects associated with the short-term side effects about bleeding, infection, the swelling in the penis for some time. And I also would tell him that he would avoid sex for at least 4 to 6 weeks after the procedure and so on.
Okay, what are the, how would you counsel him if he was going for a grafting, an incision and grafting procedure?
In addition to the basic principles or basic steps of the surgery, as I mentioned above, there are certain important things which is different from the other procedure. One is the erectile function dysfunction rate is far more than the Nesbitt procedure. It may reach up to 25%. That is one.
It's probably about 40 to 50, actually. Oh, it's very high, especially if they're diabetic or they've already got ED.
Okay. And then I would tell them about altered sensation after the surgery. So these are the two main things I would warn him about compared to the Nesbitt procedure. Okay,
so have you done a Nesbitt procedure before?
Yeah, I have assisted a few.
Okay, roughly, without giving me too much detail, how is it performed? Just
So, I mean, the patient, usually we do it under general anesthesia, or spinal also can be done. What we normally do is we do a degloving after cleaning and prepping. We do a degloving the penile skin, and with a butterfly needle, artificial erection is induced with normal saline, and we'll see the degree of curvature. And on the side of curvature, we put stitches to make it straight. So that is a plication technique that we use. I have seen different methods and I have read about different methods. What my consultant did is like put a few stitches depending on the degree of curvature to make it straight. And after the procedure, we do another induced erection to make sure that it is straight, and then usually a ethibond suture is used to do the plication, and then after that the skin is closed.
Okay, so you've just come back from holiday. You're on call again. There's a chap who's just presented. He's 32, and he developed sharp penile discomfort while he was having sex. What are your concerns, and what are you going to look for in the history?
My first concern is this might be due to penile fracture, so I would see him immediately in the A&E. Certain things I want to ask in the history. First thing is usually the penile history, the penile fracture, the history would be like sharp onset, sudden detumescence with a pop-off sound, followed by bruising and swollen penis, which looks like an aborigine sign. So I would ensure that the history is compatible with that. If it is so, I'll move on to take some more information from him. First thing is there any unusual position and the unfamiliar partner, whether he used any drugs or injections for penile erection, whether he takes any illicit drugs, and is there any previous history, similar history, whether he passed urine, is there any history of hematuria, difficulty in voiding to exclude any associated urethral injury. And also I would like to know about his past medical history, his drugs, whether he's taking any blood thinners, and last time when he ate and drink.
Okay, so he's normally fit and well. He was just having sex with his partner, although he doesn't want you to tell his wife that he's been in hospital. And he's had a bit of hematuria, but it's settled. But he hasn't been able to have sex since this all happened, approximately 6 hours ago. And he did hear a snap when this happened. So what do you think you'll see when you examine him?
On inspection, it will be a swollen penis, bruised swollen penis with the, as I told earlier, it looks like an aborigine. And if there is a breach into the box fascia, I might see a butterfly pattern hematoma as well. And on palpation, I would feel the defect. Usually the defect occurs in the ventral aspect in the proximal to middle third. And if the
I'm just going to interrupt you there. Why is that the classic position?
Sorry, come again. I couldn't hear you properly. Sorry.
Why does the fracture tend to be proximal and ventral?
Yeah, that is the place that the tunica albuginea lacks 2 layers. In the ventral aspect, we have 2 layers, and that is the thinnest part of the tunica albuginea in the ventral aspect. So that is more prone to have a fracture.
Okay, cool. Carry on.
So I would see whether I can feel any defect and sometimes hematoma. And again, I would investigate. I would inspect the meatus to see any blood in the meatus.
Okay.
And the foreskin status as well.
And the what status?
A foreskin, whether he has been circumcised or not.
Okay. So he hasn't been circumcised. The whole penis looks like an aubergine. It's very, very bruised. He does have a butterfly pattern in the perineum. What are you going to do next?
The history and examination finding is very much suggestive of penile fracture. So I would like to take him to theatre for a repair of penile fracture at this point.
Okay. So just as you're consenting him, he tells you that his father's actually a medical legal solicitor. Would you rethink taking him to theatre straight away?
No, because history is very suggestive. Examination finding is suggestive. So I'll give him the option. I'll tell him that there is the conservative management has shown us a poor outcome on long term as far as the erectile function is concerned. So I would explain him my findings, and I would tell him that clinically it's more likely to be penile fracture. So early surgery would be beneficial him for his long-term erectile function is concerned. But similarly, I'll warn him that we cannot reassure that 100% return of erectile dysfunction even we do the surgery at this point. So I would tell him, document that in my notes, and then if he's willing, take the consent. And I would explain the other risk as well as with the surgery, like infection, bleeding, and so on, and bruising and so on, and need for circumcision if needed.
Sure. Are there any guidelines or any consensus documents about imaging before surgery?
Yeah, I know it's mentioned in EU guidelines. If the equivocal cases, you can go for MRI scan. So as you said, like is aubergine, butterfly sign, and history suggestive. So it's not equivocal. So I would, I'm not very much in favor of MRI at this point.
Has BAUS produced any guidelines recommending imaging?
I have to look for that. Sorry about it.
There's a clue in that. What are the pros and cons of imaging?
The benefit of imaging, as I told earlier, in equivocal cases, like sometimes the dorsal venile system.
No. What are the pros and cons of imaging. in this case?
Okay. One is if we can locate a particular place of tunical rupture, then we can plan our incision. So that is one of the benefit. And since if it goes for medical legal case in future, so we can prove that scientifically we had evidence of penile fracture before we went on to the surgery, and also associated urethral injury also can be diagnosed in MRI.
So what are the disadvantages of doing imaging?
One is the availability. If, I don't know, depending on the time and availability of the MRI. What that is one. The second thing is discomfort to the patient because, yeah, discomfort.
How long? So he turns up at 2 o'clock in the morning. When are you going to do his fracture?
I can wait till the morning. I can do as a first case in the emergency list. So we don't need to do as an emergency because we have enough evidence that it can be done. Some papers say up to 7 days, but I can do it in the morning. I'm not going to.
Yeah. So I'm pretty sure there's a Baus consensus paper that recommends that these patients should have imaging before. There are no disadvantages to imaging this guy. I would be very, very cautious about taking him to theatre without knowing he definitely has a fracture. You wouldn't do it for any other condition in medicine. Just take them to theatre and try and guess where the injury is. So why would you do it with the penis? So you can either do an ultrasound or an MRI, depending on your availability. The MRI can be done by anybody, and you can have a look at it yourself to try and identify the fracture, or you can have the images transferred to your nearest andrology centre to have them look at it. The reason why you do that, one, you confirm that there's actually a fracture. Two, you confirm the location, and then that will determine where you make your incision. Now, as you said before, it's likely to be proximal and ventral, but most people will deglove the penis, which is not great because it's all bruised, swollen. You're doing a procedure that you may not have done for many years. Sometimes on your own, you're making your life difficult. So it's a difficult operation to deglove the penis nicely through all of that horrible tissue. So you end up devascularizing the foreskin, which means you then have to circumcise him unnecessarily. So when you confirm where the fracture is, you can then either make an incision over that point, or you can either make a midline incision over the urethra and then find the fracture, or you can make a penis scrotal transverse incision to find the fracture, and you can avoid all of that horrible tissue. So you're that much closer. So I would always advocate scanning before. If you delay by a couple of days, taking him to theatre so you can get the scan, you haven't lost anything. Yeah.
Okay, so I mean, routinely you want to image him, right? Not.
Yeah.
Is it because of this patient's medical legal this thing, or routinely you do?
I think I routinely do that. I think it would be difficult to argue in a course of law why you didn't do it. I'm not sure that there would be very many andrologists in the UK who would support not imaging him, and that's the difficulty, because that's who's going to be called in as an expert witness, especially because Baus recommends imaging these patients.
Okay.
Okay. So how are you going to? I've sort of told you the answers for the next one. How would you? So he tells you that he's had some hematuria. How are you going to assess the urethra for a urethral injury?
Yeah, we have two options. Either we can do a retrograde urethrogram or do a cystoscopy in the theater. So if you're taking to theater, I think that is the easy option to do. So I would do a cystoscopy to make sure that the urethra is patent and no injuries. And yeah.
Okay. What percentage of patients with penile fractures will have a urethral injury?
Up to 20% can have.
Okay. And how are you going to repair this fracture once you found it?
I would do a primary repair with a 4O vicryl absorbable suture over a catheter. I put a catheter and leave it for 1 week.
Okay. So I wouldn't use vicryl. I'd normally use PDS. I wouldn't leave a catheter in for a week unless he's got a urethral injury. Yeah?
No. So you said you don't leave a catheter?
Not routinely, definitely not for 2 weeks. I just repair the fracture and close.
No, it's because the urethral repair. If you do a
urethral... Okay, fine. Okay, how are you going to follow up this chap?
On discharge, I would tell him to avoid sex for at least 6 weeks, and I would like to review him after 6 weeks in the andrology clinic with the IEF questionnaire filled again to see his current erectile function status.
Okay. We're at an hour. How are you? How are you feeling? You've actually done very well. It probably didn't sound like that. You've done very, very well.
Oh my goodness!
I tried to take it all over the place.
Yeah. It is good. It was a very good practice for me, to be honest. I mean,
The only thing I would say is you just need to tighten up with your assessment answers. So you just want to be much more snappy in terms of when you're assessing the patients. It's a focused history and examination. You want to have a couple of questions. You want to get that out in less than a minute, really, because in the real exam, they're not giving you marks for taking a history and examination. So you want to get through that super quickly so you get to the juicy bits where you start to pick up marks.
okay.
And you just have to be a little bit more confident in your answers. You've got very good andrology knowledge, actually, much better than most people I examine. But you don't always come across as confident. So you have to think of yourself as you are the consultant and you're having a conversation with another consultant. Yeah. But no, I thought you did very well.
And one thing I want to ask, like in the exam, the imaging, I went in the other way and then I gave my reasons. Do you think it's a huge mistake to fail, or I mean?
No, I think if you can justify it. I'm playing I'm a little bit biased because I'm an andrologist, but I think if they ask you about imaging, you have to have a good reason for not imaging, and you have to be able to say, well, these are the pros, these are the cons. If you said, look, in my centre, there's no way, I don't have a radiologist who can do a penile MRI or a penile ultrasound. I know that there is some advice, there is some guidelines that you should image. These are the reasons why they're there. But in my centre, we just don't have that availability. So it's either I transfer him out, or he's got a very good history. His examination is very in keeping with a penile fracture. I'll counsel the patient fully about pros and cons of not doing imaging, and I would take him to theatre. But you just have to be aware that, the imaging is probably the gold standard. And most andrologists, if you've got an andrologist on the table, they're probably going to push you to image this guy beforehand. But which you're not always going to have an andrologist on the andrology table. Most of the time you won't. And most non-andrologists probably would give the same answer you did, but we're trying to move that. We're trying to move everyone away from that, to be honest.
Okay. So I'll try to find out if there's a consensus about that. Then if you have, because I read EAU clearly says that in equivocal cases, that's why I quoted. But anyways, it's good.
Yeah, sure. No, it was good that you quoted that. I'm pretty sure it was Asif and.
What's the time?
Sure, I am sure.
But I think it was Mark Lucky and Asif have done a Bausch consensus on penile fracture. So it would be worth reading that.
The Privatism one was very nice, actually. That gives the Privatism.
Yeah, no.
Very nice. The consensus, Bausch consensus Privatism. It's a very nice short document.
Yeah, it is. Yeah, it is. It's a very good one. Did you have any other questions?
Yeah, I have one more question, actually. Like in obstructive azoospermia, do we need to say about karyotyping in the answer if they ask for investigations?
Yes. So anybody who's got azoospermia, you would do karyotyping and genetics on.
Why? This came up during our discussion. Why, if this this clear-cut obstructive, so why do you want to do that?
Yeah, no, that's a good reason. That's a good question. I tend to do genetics and karyotyping at. I don't have a good reason, actually. You don't, strictly speaking, you don't need to. if it's definitely obstructive, but you may not confirm that it's obstructive until later on. And often the picture can be equivocal. But if it's obviously obstructive, then no, you probably don't need to do karyotyping or genetics.
Ayo, can I add something? Is it okay?
Yeah, sure.
Yeah, I think Ayo, even if it is like an obstructive picture, in case if the patient is going down the proper infertility service, there is a good amount of expenditure, like sperm retrieval, maybe like in vitro sterilization, and so much of finance going
Additional.
to be spent on it. And so I think with that expense, if we ended up having a baby with a genetic deformity or something, I think it's nice to screen so that we can invest in an appropriate scenario, isn't it?
Not really, because if they're obstructive and it's a clear obstruction because they've had a hernia repair as a child, or they've had a vasectomy that they forgot to tell you about, or they've had something like orchitis previously, any of the things that will cause an obvious obstruction and you can feel it, and it's not a genetic obstruction, like you can have bilateral absence of vas, where you don't have the vas on either side and it will feel obstructed. Now that you should probably do genetics for and karyotyping. But if there's a clear history and a clear picture of obstructive azo, then strictly speaking, you don't need to, but often it's not that clear cut.
But for the exam, we have to tell that, isn't it? That's what
I would say. Generally, the advice is if they've got azo, that you should do genetics and karyotyping. But you could argue that in obstructive, you don't really need to. Yeah.
And one thing you asked in between, we missed that. The Klinefelters, is there anything specific to counsel the patient? I couldn't find anything.
Oh no, it's just that their chances, they tend to have very, very small testes, very small, very soft.
Right.
So the chance when you open it, it's all scarred up, and often you don't find sperm. Okay. And then the other thing is when you take what you can that looks like it might be viable, but because they've already got small testes, they run a higher risk of becoming more hypogonadal than they may already be from that surgery. So you've got to monitor them long term. So they start off, they're likely over time to drop into hypogonadism, even if you do nothing to them. So they need endocrine long term. Okay. If you do a microtesia on them, you may make that situation worse. And the fact that they've got Klinefelters means that your chances of retrieving sperm successfully is lower than the general population of non-Klinefelters. So that's all it means, really. And obviously, if they've got Klinefelters, then there's a risk that they'll pass that on to their kids as well.
In your practice, this hypogonadism, do you treat them or you refer to endocrinology? What should we tell in the exam?
I personally don't treat them because I don't have time. I'm just too busy. So I think for the exam purposes, it depends on, you will be expected to know about hypogonadism and how to treat it. But I think it's not unreasonable to say, these are the things in my practice, I don't directly treat these patients. I would refer them to an endocrinologist or an andrologist who also does hypogonadism. However, these are the treatment options, these are the pros and cons, etc., etc. You will be expected to know that and know how to treat them for the exam.
Thank you. Thank you. That's useful.
No problem.
Thank you, Ayo. Thank you for your time on a weekend. No problem. That was a brilliant, that was a very brilliant session. Thank you for our trainee to volunteering, because this will really help many trainees, not only for this May 2021 batch, even for the future. And I'm very sure a lot of trainees will join us in the YouTube channel to use this as a good resource tool and also as a good revision tool. And for the trainees who are seeing in the YouTube, now they will be seeing another interesting andrology case discussion on the left-hand side, and our YouTube series on the right-hand side, and the subscribe button in the center. And I'm sure most of them have already subscribed to us.